Hello, and welcome to the first part of our 2020 Opioids webinar series, The Relationship Between Opioids and Brain Injury and Harm Reduction Strategies offered by the National Association of Statewide Head Injury Administrators. I am Gabriela Lawrence Soto, NASHIA's Training and Education Committee Chair, and Maria Crowley, NASHIA's Director of Professional Development, is our webinar organizer today. Thank you for joining us. NASHIA is a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injuries and their families. A GoToWebinar user guide is available for download from the NASHIA website. This is a great resource for making the most out of your live webinar experiences. Handouts of today's presentation are available for download. Check your attendee control panel for the handouts pane. To ask questions during the webinar, please submit it in the questions pane on your control panel, and your organizer will forward your questions to our presenter at the end of the presentation. If we run out of time, the presenters will respond to your questions via email. For continuing education credits for social workers and certified rehabilitation counseling, as well as general certificates of attendance, are available for today's event. At the end of the webinar, you will receive an evaluation and instructions on obtaining credits via email. The webinar will also be archived for later access on our website. I would like to introduce our presenters for today. Anastasia Edmonston and Laura Bartolomei-Hill with the Maryland Behavioral Health Administration. Stasia is a project coordinator for the Maryland's Traumatic Brain Injury Grant and has worked in the field of rehabilitation services for individuals with traumatic and acquired brain injuries for over 30 years, providing training on traumatic brain injury, person-centered thinking, aging, mental health, and addiction, and law enforcement. Laura is a social worker specializing in harm reduction, drug use, and TBI in both inpatient and community-based settings. Welcome to you both.
Hi, everybody. How are you? So today, Stacia and I are going to be covering the relationship between opioids and brain injury and harm reduction strategies through a brain injury informed lens. Go to the next slide, please. So today we'll discuss the link between brain injury and opioids, harm reduction as it relates to individuals who have a history of brain injury and/or people who use drugs, the role of stigma and racism in shaping cultural attitudes towards drug use, suggested strategies and tools to engage public health and behavioral health professionals, and suggested strategies and resources to support individuals. Okay, next slide. So who is with us here today? Okay, cool. So it looks like just around a quarter of the people on the phone are a state brain injury program provider. About 15% are mental health or addictions providers. 3% are individuals with a brain injury or a family member, and everyone else clicked other. So if you clicked other, I think, go ahead and type in how you define yourself into the chat. That'd be great. Okay, we'll go to the next slide. Okay, so I'm going to start off today talking a little bit about overdose. So overdose, as many of you know, has been in the news quite a bit over the last few years. There's been a little bit less news coverage lately, but that doesn't mean that the problem has stopped or has been reduced at all. According to the CDC, nearly 72,000 people died of a drug-related death in 2019, and around 70% of those deaths involved opioids. Many of those involve synthetic opioids, such as fentanyl, which can be more potent, a little bit stronger, and can be less expensive to manufacture and transport. In 2017, there were around 300,000 non-fatal overdoses treated in US emergency departments. And I highlighted this here for a couple of reasons. The first reason is to highlight about how many overdoses we're considering may be individuals who would benefit from being screened for a traumatic brain injury, or sorry, a anoxic brain injury. I also want to highlight here that this 300,000 is probably a fraction of the total overdoses that occur, as many overdoses are revived in the field by peers or by first responders. And so we're looking at quite a huge population of people here who would benefit from brain injury screening, even if they're not hitting the emergency room. Okay, we can go to the next one. So during the pandemic, I wanted to take a minute here to talk about what overdose has been like during the pandemic. These numbers, so I have here that overdose deaths have increased by 13% so far this year over 2019, and that's based on data from June. There's a number of reasons that overdose deaths could have increased over the past few months during the pandemic. There's been some pretty significant disruptions in in-person treatment, including NANA meetings and other medical and mental health programs. I know that the Suboxone program that I work in moved from an in-person experience to entirely virtual, including for groups, which has been quite affecting for the people who are in the program. We're also seeing worsening psychosocial stressors, including loss of insurance, losing your housing, job loss, difficulty with childcare, access to medical care for other issues as well. Social distancing means that people are alone more often and fewer people might be around to respond to an overdose. One of the biggest groups of people who are responding to overdoses are other people who are using or who are peers to the person who may have overdosed. And so if people are using alone more often, that means that they're less likely to be around someone else who could administer Narcan or call 911. The final one is that because of the pandemic, there's been some restricted migration and trade patterns have changed, and that's made the drug supply less predictable. I know from a lot of the people that I've talked to in the program that I work in, people are just reporting that the drugs feel different than they did 6 months ago, and that it's less consistent from day to day. Okay, you can go to the next slide. I want to talk here about non-fatal overdose as a brain injury. And this is thinking back here to those 300,000 people and more who, presented to the emergency room, and also those who are not presenting to the emergency room. And this is that group of people that we really are focusing on today. So individuals who sustain a brain injury from a non-fatal overdose may struggle to abstain from drugs even when abstinence is their goal. They might have difficulty adhering to treatment program rules, for a variety of reasons related to the injury. They might choose to use drugs for a variety of reasons. This can include relief from psychological or physical pain. And then they also should have access to resources to use drugs more safely and to treatment programs that can accommodate their individual needs. So for people who are having difficulty adhering to program rules that may be rigid, that our program should start to take a more proactive way in addressing individual needs. Okay, you can go to the next one. So one of the strategies that I'm going to talk about today is called harm reduction. And some of you might be familiar with harm reduction. I know there are a lot of different definitions for harm reduction out in the world. So this is the definition that I use in my work that I wanted to introduce today. This definition comes from the Baltimore Harm Reduction Coalition. It states that harm reduction is both a philosophy and a set of practices applied to promote safety associated with culturally stigmatized behaviors such as drug use and sex work. And we're talking here about harm reduction being practiced on two levels. The first is what I call the interpersonal level. The interpersonal level is where we change our routines, we distribute tools for increasing safety, we really look at those different individual behaviors. And the second area of harm reduction to focus on is the institutional, where we're thinking about changing policies and changing systems to support safety and to decrease violence. Next slide. Can you go back one, please? Thank you. So harm reduction on the interpersonal level, this might be what a lot of people associate with harm reduction. So this can include distributing naloxone, which is the overdose reversal medication. It can include needle exchange or syringe service programs. It can include giving out condoms and other safer sex materials, and include overdose prevention sites, which are not legal in the United States, but are pretty well established throughout many other countries in the world and are one of the leading tools for reducing overdose deaths. You can see here, this is an example of a syringe service program. That is me at a program here in my neighborhood at the church next door to my house. And we give out syringes as well as smoking and snorting kits and condoms and naloxone and all sorts of fun stuff. So you can go to the next slide, please. The definition part of harm reduction that I want to cover here that might be a little bit less familiar to people is the idea of harm reduction on the institutional level. So this is thinking about policies and practices, and this can include advocating for increased access to healthcare, reconsidering the severity of punishments for individual behaviors, including drug use and sex work, which are deeply both criminalized and punished in other settings. You can assess how your agency or your organization might perpetuate stigma and make an action plan to change those practices and cultures. So many of us may not be, I believe that all of us should be advocating on both a state and local level legislatively, but there's also an opportunity to examine the way that your programs specifically work from a harm reduction lens. So on our next slide, I'll talk about how one of the programs that I work for used a harm reduction lens to consider the way that we were impacting our patients. So there's a handout here. You can take a look at it after the webinar, but it's a set of questions that I call a harm reduction organizational analysis. And this is a tool that can be used to look at your program's policies and practices and consider their impacts on both the staff and on your clients. So some of the questions that included here are, what are our stated and unstated goals and expectations for the clients? How do our policies and practices reflect the priorities of the criminal justice system, including surveillance, abstinence, and punishment? Do staff team members feel like their knowledge and experience is valued? And what feedback are we getting on the impact of these practices? So if we can go to the next slide, please. So this is the outcome, and I won't read all of this. It's a lot of words on a slide, I understand. So this is the outcome, though, of an organizational analysis that one of the treatment programs that I work for used in considering our policies and practices a few years ago. And the question that we specifically wanted to ask ourselves is, how are we harming our clients? Not intentionally, but how are our policies and practices actually harming the people that we're hoping to serve? And so this definition of harm reduction is really looking not just at the harms that are kind of inherent in the behavior, but in really asking ourselves, how are the choices that we're making as an organization harming the people that we're serving? And what are the opportunities for reducing those harms by changing our policies and practices? So some of the outcomes that we came up with, so the first was an overemphasis on abstinence leads individuals to hide or downplay their drug use. So when we were talking to our patients so much about from an abstinence-based perspective, people were not they were not feeling safe to be honest about their use. And so instead, the way we changed it is we started to incentivize progress on individual identified goals and removed any penalties or punishments for drug use. The next one is that we looked at an increased sense of shame when unable to meet unrealistic expectations. There's so much shame and stigma directed towards people who use drugs in the healthcare system that it was really painful to think about how we were contributing to that. And so when we were asking people to accomplish an unrealistic amount of things through our program, then the people were feeling bad because they weren't able to accomplish that when it wasn't a realistic expectation in the first place. So we started to be more intentional about removing requirements about attending specific numbers of groups and encouraged and recognized a variety of social supports. And so concretely what this looked like is a few years ago, we required that patients attended 6 or 7 groups each week. And people were there was like one person who was doing it and everybody else wasn't, and everybody felt bad about it, or they were not being honest about it to us. And either way, it wasn't helping the therapeutic relationship and it wasn't helping the patients. And so when we removed the requirement around attending a specific number of groups, we also use that as an opportunity to encourage and recognize that group therapy is not the only type of support that individuals use to achieve change. And specifically for those individuals who had a history of overdose and potentially had had a history of brain injury, that we recognized that group settings could be really difficult for people who have a history of brain injury, and that by opening up the program to other types of social supports and program supports, that we were being a little bit more accommodating to a variety of cognitive needs. And so, I mean, I won't go through all of them, but I think the last one I'll touch on is that we were ignoring the context of a racialized drug policy. So many of the individuals who come into our program, which is designed to help people who are using drugs, are, you know, we don't talk about the policies that have affected their lives. And I'll get into this in the slides that are coming next. But it's really important to validate experiences, to advocate for those in other healthcare settings. There's been a number of times that the patients in our program will call me and say, I'm in the hospital. Can you talk to my doctor here and explain that I'm on Suboxone for this reason? Or can you tell them that I'm not just here because I'm trying to trick someone into give me pain medication? And so advocating for others in healthcare settings is super important. And then also making space for political advocacy. We've had patients who have gone on to, they have shared about overdose prevention sites. They participated in advocacy in the city and at the state level. And we really try to create a space for that. Okay, so next slide. Okay, I'm gonna ask everyone just to take a minute to check in with yourself. So the question that I'd like you to check in with yourself is, why do we think what we think about drugs? And so there's a couple of questions that I'll give you to consider. One is, what is your immediate reaction when you think about drug use or thinking about people who use drugs? What comes to mind? Do you have an immediate reaction to different substances? Is it different if somebody says, oh, I'm going to have a glass of wine with dinner tonight, versus someone who is reporting to you the use of something that's criminalized, such as heroin or cocaine? And do you feel like some drugs are worse than others, and why? Okay, I'm going to give you 30 seconds to just take a minute and think about, check in with yourself. Where are you at today? What's your immediate reaction? There's nothing that's a wrong answer. It's just about reflecting on where you are. Okay, I'm going to give you 30 seconds. Okay, that feels like 30 seconds. All right, we can go on to the next one. All right, so part of this is to, I'm hoping now to answer some of, or to provide more to reflect on in terms of why we think what we think about drug use. And to start with, I'm going to go back to historical responses to drug use. The prohibition of drugs is just it's like in the history of people using mind-altering substances, prohibition is a relatively new phenomenon. So for many centuries, people have used various substances to have different experiences. And the restriction and prohibition of those substances, while dating back a few centuries, is still in the history of human experience relatively new. So we're going to first look at, I'm just going to pick out a few examples over the history of US drug policy to check in on. So the first thing we're going to talk about is opium use and restriction in the late 1800s to the early 1900s. So there's a couple of things happening during this time. The Chinese practice of opium dens was brought to the US around the 1850s. In the 1890s, the US government imposed a tax on opium with the first narcotic restriction legislation in the country's history. And during that time, there were a number of newspaper articles, media stories about the dangers of white women being seduced by Chinese men and their opium. And so from the beginning, the language that we've used around drug restriction was really linked to a racialized understanding of substance use. And there was also the phenomenon where in the late 1800s, a lot of the primary opioid users were women. And this is a quote from a historian, and I don't necessarily agree with the specific language that he's using, but what he says is that as in the late 19th century, talking about most of the people who were using opioids as being white women, as this idea of the most common kind of narcotic addict was a sick old lady, a morphine or opium user, people weren't really interested in throwing them in jail. It was a scandal, but it wasn't a crime. But when the typical drug user, at least the one in people's imaginations, became a young person on the corner hanging out with his friends and snorting heroin, it becomes a less sympathetic picture of narcotic addiction. And so what I want to focus on here is that it isn't the drug itself, it's the portrayal of it and what it's associated with. Okay, we can go to the next slide, please. The next time I want to jump forward to the 1930s, and we're going to introduce Harry Anslinger, who was the director of the Federal Bureau of Narcotics for several decades, and he led advocacy for what's called the Marijuana Tax Act of 1937, which made marijuana illegal. From the 1890s to the 1930s, Anslinger and William Randolph Hearst, who was a newspaper publisher, used these stories of racism and sensationalism to campaign for marijuana criminalization. And these frequently tied drug use by African Americans and by Mexican immigrants to sexual violence against white women. And so below there's a quote from Anslinger that you can review, but really as we move from the criminalization and restriction of opioid use through the 1930s when we're looking at marijuana, the people who are leading for the advocacy of the prohibition and the criminalization of these substances are using extremely racialized language and racialized images to promote their efforts. And so it isn't really about the marijuana, it's about the sensation that people are associating this kind of sexual violence against white women and using that racist language to criminalize this drug. Okay, next slide. Then we're going to jump to the 1970s, and I'm just doing some brief examples here because we only have a little bit. Jump to the 1970s when President Nixon declared the war on drugs, including the creation of the Drug Enforcement Agency. This ushered in a new era of mass incarceration, of mandatory minimums, and more severe sentencing for drug use and possession. And although rates of drug use is similar across racial groups, Black people and Latinx people are disproportionately arrested, charged, and convicted of drug-related crimes. Okay, next slide. So you might be wondering, what does this have to do with brain injury? What does this have to do with healthcare? So what I'm trying to the argument that I'm trying to make here, the narrative that I'm trying to build is that this history of criminalization has a direct effect on how we treat people who use drugs and the type of services that are provided to people who use drugs. And as more and more people who use drugs are going to be entering or should be entering brain injury programs as a result of the overdose crisis, that brain injury providers specifically really need to have a deep understanding of how this history of criminalization affects the healthcare system and also affects the people who are entering into the program, as well as how the history of criminalization and this centuries of media stories that are telling us about how terrible drugs are can affect ourselves as program providers and as healthcare providers. So the first drug treatment programs were actually in criminal justice settings, in jails and prisons, which was the first place where drug treatment and what we now call substance use disorder treatment came to be. And so the legacy of a lot of those models are really based in a criminalization context. And so some of what that can look like is that the goals and expectations are often set by the program, not by the client. So when someone comes into into a drug treatment program, the goal is set by the program, which often is an abstinence-related goal. Traditional substance use disorder approaches are often centered on abstinence, and there are few services for people who use drugs outside of that perspective. And for people in court-mandated treatment, abstinence is often mandated. So they're taking the goal and expectation part of the program and they're moving it from an individual to the program. That there is a huge amount of surveillance and monitoring, often through urine drug screens, that you don't really see in other types of healthcare settings. That there's punishment and consequences for drug use, and that there's a lot of resentment. And I've seen this a lot both in the hospital that I work in and in talking to other treatment providers and talking to my patients and helping them navigate the healthcare system, is that there's a huge amount of resentment from healthcare providers towards people who use drugs. And really examining where that comes from and doing some of that self-check-in, I think, is really important as you're considering how do you make your services more welcoming to people who use drugs, and how are you not harming the people who are entering your programs. Okay, next slide. So I have a couple slides now about implications for brain injury treatment. And this is just touching the surface. So I only have a few minutes left, but I wanted to just introduce a few concepts here. So the first one is that cultural attitudes around drug use have a really real impact on individuals and on communities in a variety of settings, including in drug treatment settings, including in brain injury settings, that there's a lot in, sometimes I think about it as being like the air. It's in the air, you don't see it, you don't notice it all the time, but it's around you and it's affecting everything that you're doing. That people who use drugs often avoid coming into healthcare spaces due to both the practical concerns, receiving poor care, untreated withdrawal symptoms, and from the shame and judgment from healthcare providers. And I've seen this firsthand in the people that I work with, and in hearing stories from the patients that I see in my program. Many overdose deaths are preventable, and that political will is the primary barrier to enacting policies that could save lives. Like I said, that there are a number of programs that have significantly reduced overdose deaths in other countries that the United States is unwilling to adopt, not because there isn't the evidence for it, but because there's a barrier in political will. But many of the deaths that we're seeing, those 150,000 people who have overdosed, had died from an overdose in the past 2 years. Many of those deaths are preventable, and it's a choice that we're making as a society to not do more to prevent that. Okay, next slide. The overdose crisis will increasingly bring people who use drugs or have a history of involvement in the criminal justice system into brain injury programs. So as a brain injury program, it's really important to really be focused on and learning about the effect of that criminalization on the population that may be entering your programs. Recognize the barriers that criminalization of drugs may impose on individuals engaged in your clinical programs, including access to care, and that there's a lot of shame and marginalization that can complicate the development of a trusting therapeutic relationship. I really try to put a lot of intention into developing a therapeutic relationship with my clients that acknowledges a lot of the shame and marginalization that they have experienced. And just last week, one of my patients said, "I don't know if you realize that you're doing this, but," and she's like, "I can tell that you really feel strongly about this, and I think that's really more about your feelings than me. And I think you're kind of like taking that out on me." And she and I had worked together. We worked together for several years, and I really appreciated that having a relationship where someone can say, "You're doing something that's hurting me, and I want you to stop." And yeah, I really appreciated that, and I hope that's the kind of like dynamic that I feel really can really help. Okay, next slide. So a few tools for brain injury providers in the last couple minutes that I have. Being flexible with rules, particularly around group attendance and participation, and allowing for participants to take breaks as needed. This is really difficult. I know that a lot of people do a lot of billing through group participation, especially in substance use disorder treatment settings. But I know that from working with the people who have a history of overdose or who have been formally diagnosed with a brain injury who come into the programs that I work in, that sometimes sitting through an hour-long group is like just too much. Like it's too much. It's too much stimulation. You need a break. And so as a provider, I really try to provide, I tell everyone, if you want to leave, you can leave. If you want to come today, you can come today. If you need a break, go take a break. And just giving people the space to make those decisions that feel right for themselves. The focus on routines and behaviors as much as on internal motivation. So this, I think, should feel more familiar to you all than it usually does to substance use treatment providers. But thinking about not just on helping people develop the supports around themselves instead of purely focusing on internal motivations for change. And then using really concrete safety plans with external supports to better understand specific risks and to increase safety for the people who you're working with. And I can send around some examples of safety plans if that would be helpful. Okay, next slide. Okay, so this is my final slide that I want to close on. This is a quote from Audre Lorde, who is a feminist philosopher. And this says, "And that deep and irreplaceable knowledge of my capacity for joy comes to demand from all of my life that it be lived within that knowledge that such satisfaction is possible." And this, I come back to this quote all the time. It really means quite a lot to me. And I think about it in that story that I was telling you all about, the interaction I had with my client, where when she first entered the program, she had such shame and she expected such shame from her healthcare providers. And over the past few years, she's really had a transformation for that. That now when she experienced what I was saying as, as trying to shame her, she was like, I don't have a tolerance for that anymore. And my capacity for joy comes to demand from all of my life that I be lived with that. And now that I know that living a life without shame is possible, I can't tolerate that from my healthcare providers, from the people in my family. And so I really want us to move to a place where we're giving people the support and space to live without shame and to be open to hearing from the people that it affects, when our choices and our behaviors are leading them to live less than they can. Okay, thank you all so much. It was really nice to talk with you all today, and I'm going to turn it over to Stacia.
Thank you, Laura. I'm Stacia Edmonston. I'm with Behavioral Health Administration in Maryland, and we have the Federal Traumatic Brain Injury Partner Grant. We are in year 3. So I just want to give you a little bit of background about that. One of the things that we are working on as part of our grant is collaborating with our overdose fatality review teams through the Maryland Department of Health Office of Health Improvements. We've been doing pre-COVID a lot of in-person training with the local behavioral health administrations offices in the counties, and also been working with the overdose fatality review teams and their technical assistance calls bi-monthly, and then in person to meetings, overdose review meetings when requested. So the other things that we've been doing is collaborating with our partners in the local behavioral health departments to co-present with us at the Brain Injury Association of Maryland's conference, and also at the Division of Rehabilitation Services conference. Just trying to get the word out there. We co-present workshops on brain injury and intersection of brain injury and opioids and acquired brain injury, and then we have the certified peer specialists affiliated with those counties set up a table and certify people to administer naloxone. So we're really trying to reach across, not only in our brain injury community, but also in the disabilities community. So I just want to say that this work with the overdose fatality review teams really began prior to this grant, and it is due to Laura, who was working as the Maryland Overdose Fatality Review Coordinator, when she approached us and said, I think we have something in common. And we are quite aware in the brain injury world that people can have an acquired brain injury, and some mechanisms of acquired brain injury are overdoses. And so we thought that's what she wanted to talk to us about. And she said, well, yeah, but she said in overdose fatality review, it's not a huge trend, but we're noticing when we review people who have passed of an overdose that some of them have a history of a traumatic brain injury. Let's start working together. And so when we had the opportunity to apply for this grant, we decided to make collaborating with the overdose fatality review teams one of our top priorities. So, but what is overdose fatality review? So the next few slides are courtesy of Brooke Holmes. She's the program administrator in the Office of Health Improvement. And so she and I and Dr. Shaw, who is an overdose fatality review coordinator at Prince George's County, were to present these slides at a national conference, but it was March, and that conference we had to pull out because of COVID. So I just want to share you some nuts and bolts. And this, again, is from Brooke. You can go back to that first, thanks. So Overdose Fatality Review is a multidisciplinary team that's assembled at the local level. So in Maryland, so counties, and then Baltimore City. Right now, they're up to 23 and 24 of Maryland jurisdictions have an overdose fatality review team. And their goal is to prevent future deaths, to identify missed opportunities, building working relationships, recommending policies and programs, et cetera, and informing local and, of course, statewide prevention strategies, and also some changes in the law. So in Maryland, I think these are lessons perhaps for other states. This is relatively new, our overdose fatality review team. The first one was established in 2013. They had a Department of Justice Harold Rogers grant, and that allowed 3 teams to form. And then in 2014, expansion. In May of that year, it was established in law. So again, we have 23 out of 24 jurisdictions. And if you want more information on how that kind of built and gained momentum in our state, there is an article in the 2016 July issue of Health Promotion Practice by Kathleen Rebert Franklin et al. Next slide. So this is just what's in the law. Around the country. So this is Maryland. And I thought, well, I wonder who else is doing this. What other states around the country are forming these boards, are bringing people together, obligating agencies to provide information about people who passed of an overdose, gives the teams the authority to review those individuals' history. And I found that as of August 2019, there's only 8 states, in addition to Maryland, that have overdose fatality review teams. So this may be an opportunity, if you're listening to us today, to say, we don't have one in our state. Maybe this is something that we can start to work on and collaborate with our behavioral health partners, because we know that brain injury can precede or can be a result of an overdose or overdoses. And if you're interested, there's a really great nuts and bolt review of overdose fatality review teams, how to put them together, and the Bureau of Justice Assistance Comprehensive Opioid Stimulant and Substance Abuse Program Resource Center. So you can be looking for that. That's something you're interested in. Next slide. So this is really important, these last few bullets. The confidentiality expectations of the overdose fatality review teams. They are exceedingly sensitive and respectful of people who've passed of overdose that they are reviewing. And I think it's something that they take very, very seriously. And so I just wanted to point that out. You can go to the next slide. I also wanted to mention the Maryland Good Samaritan law. It came into effect in 2015, so after Maryland's overdose fatality review teams were established. And in 50 states and the District of Columbia have all passed Good Samaritan laws, with the exception of Oklahoma, Texas, and Wyoming. And this could be considered a harm reduction strategy. And they have made a difference. Some states have done studies that it really made a difference to get the word out, that it resulted in more people getting to the hospital following an overdose, as well as higher rates of calls to 911 when individuals who use non-medical prescription opioids are familiar with the law and make that call if they witness an overdose. So obviously the takeaway for me was, if you are working with individuals who use drugs and are living with brain injury in your programs, please make them aware if there is a Good Samaritan law in your state. In Maryland, there's been a lot of public awareness efforts around the law, billboards, et cetera. But as with anything, there are unintended consequences. And Laura has shared with me that among people who use drugs, at least in this area, in Maryland and Baltimore City, some have reported that, aware of the Good Samaritan law, they will do their due diligence and call 911 if they've witnessed an overdose, but they still may get into trouble with the police, who may still arrest them for unrelated issues such as trespassing. So no good deed goes unpunished, and that's something, of course, that we need to take into consideration, that people do not suffer untoward consequences for doing the right thing. Next slide. So this is a composition of the team broadly. So the coordinators, every team has a coordinator, can invite guests. So for example, I've been a guest at several meetings if I sign a confidentiality form, and I'm also an official member of one jurisdiction's overdose fatality review team in Prince George's County. So Just to give you a sense of how the meetings are conducted, the teams will typically meet once a quarter for about 2 hours and maybe review 4 cases of individuals who've passed during the past quarter. And cases are chosen by the coordinator. Perhaps there's a trend that they're seeing in their county, a spike in deaths, say around cocaine and fentanyl, which is something that Maryland is seeing a spike of, or a cluster of deaths in a specific area of the county. I remember seeing in one meeting where they were reporting that there were a lot of overdoses happening on county buses, on the bus lines and in the trains. And so that's an opportunity for intervention and support. So the team's review is guided by what's called the dashboard, and that requires information including demographic, medical, social, behavioral health, legal, and educational information, and that is pulled together so you can have a picture of that person's past, recent history, and then try to look for gaps where we can learn how maybe different policies can be enacted, things that should occur with folks, individually, and then at the broader level of policy. What can we do to prevent what happened to this individual that we are reviewing as part of overdose fatality review. You can go to the next slide. So I'm going to go through a hypothetical overdose fatality review case. Often when a case is chosen for a review, there isn't a lot of information regarding the decedent's history before the team meets. However, there may be some information that the team is given in advance that can prompt questions to bring up during the overdose fatality review meeting that might offer some clues that the person was living with a history of brain injury. So next slide. What I'd like us to do is as I read this case, and this is based on a conglomerate of situations, as I read through it on the next 2 slides, jot down in the chat any clues that this individual was living with a history of either a traumatic or an acquired brain injury or injuries. Next slide. So this is a 49-year-old man, passed away, was found unresponsive in his room by a roommate. The roommate initiated CPR and called 911. First responders arrived and they were unable to restore breathing. The roommate told the first responders that he had been drinking the night before, and the roommate believed he had snorted heroin as well. Additional information about the decedent's past and recent history include a bout of meningitis at the age of 10 that required hospitalization, poor academic performance that began in middle school, and around this time, his parents reported he began using alcohol and marijuana. In high school, he was involved in a car accident. The driver of the vehicle died, and he was hospitalized with a serious concussion. Next slide. So additional information available to the team was that this gentleman dropped out of high school, that he did work periodically as a delivery driver for local florists and pharmacies, as well as an auto part company. A Maryland case search reveals several short-term stays in the county detention center for theft, assault, and battery. On several occasions, he did enter outpatient treatment for substance use, but left prematurely. On at least one of those occasions, as reported, he had conflicts with fellow group members. Next. So if you've had the opportunity to jot down some thoughts, I cannot see the chat for whatever reason here. But Laura, if you want to come back on and read anything that's in the chat. Are we getting any comments?
Let me see. I think I can only see organizers.
Well, then I'm going to have to give you the answers if we can't see the chat. But I know you've all understood. If you go back, Maria, to that first of the case study, first slide of the case study. So you go back 2 slides. Okay. So if we look at this individual's history, and this is something that has come up in a few meetings that I've been privy to. Something happened in childhood. In this case, I made it up. I said meningitis. Now, we know that meningitis can be something pretty serious, and it could increase a person's risk of having an acquired brain injury. It's an inflammation of the brain. We know that after something like that, somebody may have challenges in school, might not be connected to that illness. And then as we hit middle school, we're expected to be able to take on additional responsibilities developmentally, be able to manage a more complex academic environment, social environment. But things started to happen. That might be a clue. And then, of course, the big red flag for those of us working in the brain injury community is that he had a car accident and was hospitalized with a serious concussion. For a lot of folks, concussions aren't serious or aren't thought to be serious. Next slide. You can go on to the next slide. So I'm just going to go through what you could see in terms of the brain injury informed lens that might lead us to think, So this gentleman, he, like I say, dropped out of school. That's a sign. He worked periodically, so we know he could work, but why were there gaps in his work? He had short stays in county detention center. We know that people who are incarcerated have a very high rate of often hidden brain injuries in their history. And he entered outpatient treatment. And if you remember what Laura said, a lot of people who enter traditional substance abuse treatment programs have difficulty navigating the expectations of engaging in groups, paying attention, remembering content, being able to engage with staff and their peers verbally. So all these things in this case should be clues. Perhaps this person was living with history of brain injury. Next. Next. So in cases like this, we just want to ask brain injury informed questions. So if I was sitting at the table, I would say, any health or learning challenges before the age of 10? Any changes after that meningitis? So as I was trying to prompt you to look at those slides with a case study, you want to look at these clues and kind of ask some more questions. What about after that car accident? Well, he did drop out of high school. That might mean something. Are there any records regarding specific areas of his brain that were affected by the accident? Any chronic pain following the car accident? Did he complain of headaches, orthopedic pain, trouble sleeping? Was he prescribed any medications? And do we know if there's any prior survived overdoses, which of course would be an acquired brain injury? Next. So when I did sit in on a meeting with a case that was very complicated and lots of layers, many of them blaring to me as possible history of brain injury, I broke down and I titled it Brain Injury Facts Pertinent to this case. And so in the make-believe case, we talk about bacterial meningitis. You know, what is it? What can it cause? It can look like things that can happen after an acquired brain injury or traumatic brain injury, so it affects the brain. And then traumatic brain injury, just given that basic definition, because not everybody in overdose fatality review, if they come from parole and probation, if they come from law enforcement, if they come from family services, they may not have that working definition of traumatic brain injury at the fingertips as we do. So just to reiterate that, always reiterating basic education about brain injury when working with the overdose fatality review teams. Next. And then, of course, we talk about acquired brain injury. Again, for people who don't work day in and day out in our field, it may not be something that really is apparent to them that a person could have a brain injury even without a direct blow to the head. That if somebody has a so-called just a concussion, just got their bell rung, there could be lingering issues. To understand that reduced oxygen or loss of oxygen to the brain can really impact the brain's functioning just as badly and in this basically the same parts of the brain as a traumatic brain injury. Next. And again, this is right from Drs. Corrigan and Adams. This is something that I shared there. The link is here on the slide, but share their fact sheets. And again, talking about the impact of brain injury, especially on an immature brain. So we know that the brain doesn't fully meet its make its maturity known until we're in our mid-20s. And I single out men in this because it was a man in this hypothetical case. And so that may be a reason why some poor decisions were made. I'm not excusing, I'm just explaining. Again, when we're in overdose fatality review, we're just trying to pull together the information and maybe look for clues, and then maybe there's some things that we could do to prevent in the future individuals with histories similar to this from ending up, you know, in with a overdose that is fatal. Next. And I am so concrete that I give pictures. So in the case that I'm talking about, hypothetical and real world, this was the graphic that I shared with arrows literally pointing to these vulnerable parts of our brain. Next. So I'm not going to go through every single one of these, but I just wanted to share with you some slides that are taken from the guide to the overdose fatality review team. So in Maryland, we have that dashboard that asks the team coordinator to go through the person's medical history, their social history, and look for areas that may give us clues about gaps that may have led to this adverse event of, you know, unfortunate death. So it's called a social autopsy, to kind of peel back that person's history and look for clues. And so I took that and I added some brain injury content. Now I do want to say thanks to the work that Laura did early on when they were first putting together the dashboard, there is a specific question about brain injury, and I quote, acquired brain injury, if a team member reports indicate a history of ABI, mark the checkbox. If reports do not indicate a history of acquired brain injury or status is unknown, do not check the checkbox. ABIs included concussions and other traumatic brain injuries, strokes and other brain damage incurred in events after birth. Neurodegenerative disorder or congenital disorders, including fetal alcohol syndrome, are not, in all caps, considered to be ABIs. So that is fantastic that Maryland's dashboard lays it out there, that brain injury is a consideration. But we know that brain injury is not always so obvious. We know it's hidden among populations who are in behavioral health service delivery programs. So what I did was try to help people, again, peel back the onion. So this is just a brain injury related condition. So maybe the person had a seizure disorder. Was there depression or anxiety, aggression, apathy, pain? What are common medications? So one of the things that they collect information on is medications the person was using and also medications found at the scene of death. And so what were the bottles that were around the individual or in their bathroom? And again, just because somebody is taking Zoloft does not mean that they're living with a brain injury. Of course not. But those are common medications that are often prescribed for people living with a traumatic brain injury. And I actually got this from a book by Dr. Vani Rao for the layperson, not for medical folks, about brain injury. So I tried to take it from a very good source. Next slide. We want to look at the medical services, contact with EMS, overdoses, car accidents, any emergency room admission, look for concussion, falls, assaults, acquired brain injury, stroke, cardiac arrest, epilepsy, carbon monoxide poisoning, drug overdose. Next. We want to look at law enforcement. We want to see if people have been incarcerated. We want to see if they were driving under the influence. We want to see if they were involved in juvenile services. Again, all things that might be part of living with a history of brain injury. We know about half of kids in juvenile services are living with a history of brain injury, as well as adult incarcerated individuals. Next. And again, of course, behavioral health, depression, anxiety, social isolation, suicide attempts. All those could be clues a person may be living with a brain injury. History of treatment failure, we see that a lot, that revolving door of going in and out of treatment prior to completion or being asked to leave because they were disruptive. Next. And family history, particularly intimate partner violence. Were they the victim of intimate partner violence as an adult? Were they victim of childhood abuse? And we do know that perpetrators of domestic violence, there's some studies that suggest that they also have a history of brain injury, which does not excuse their behavior, but can explain that lack of impulse control that leads to interpartner violence. Next. So we also want to know about homelessness and employment status. We know that, again, higher rates of brain injuries among people who are homeless, and people who are living with brain injury are very likely to be unemployed or underemployed. Again, these are just pieces of the picture. And you can go to the next slide. So I just want to wrap this up by saying I want to stress that bearing a documented brain injury, we are not suggesting that one factor in a person's history proves a history of brain injury. We just want the teams to be aware of possible indications and to offer clues to dig in a bit deeper during the process of overdose fatality review, connect those dots, and hopefully lead to a deeper understanding and a change in practice and policy ultimately. For example, at a recent meeting that I attended, the clues were loud and clear that the brain injury, both traumatic and acquired, was a factor in that individual's life trajectory. And after that person's story was reviewed, their probation officer remarked, I think I need to screen the people I'm working with for a history of brain injury. And the overdose fatality review coordinator, who had attended in the past brain injury project trainings that we've offered, she said, I knew there was something about this person's history. I knew they just weren't, and I quote, they're just not a jerk. So that's what we're looking for. We're looking for those aha moments that eventually transition into specific recommendations and policies to address the gaps in services and do some proactive work to prevent this. So I think I'm going to stop there, and if there's any questions, we can quickly answer them. You can always reach out to Laura and I by email, and there are lots of handouts for you, and please feel free to use them. You can modify them for your state's purposes, and I'd be happy to give you modifiable versions because there's PDF versions in the handouts.
Gabby, we can't hear you.
Can you hear me now?
Yeah.
Okay, the question is, do you consider strangulation as a brain injury?
Yes, that would be an acquired brain injury secondary to loss of oxygen to the brain. And just like with repeated concussions or survivable overdoses, those repeated insults to the brain can add up to really cause functional issues. And Laura, I don't know if you want to add anything to that.
Great. So there are no other questions for today. So I want to thank you, Stasia, for your time. If you enjoyed today's event, stay tuned for the opioids webinar follow-up. We have a webinar coming up called Building and Leveraging Partnerships with Providers on November 18th, 2020. And check out other announcements about some of the other training events, as well as our 2021 webinars, products, podcasts, and Leading Practice Academy series. We want to thank you all for viewing this webinar today. Please contact us to receive notice of future events and other resources. Our archived webinars are available online, and we would love to have you as a member. So please visit us at www.nashia.org. Don't forget to complete the evaluation at the end of this webinar. Your CEUs will be available to you in about an hour after this webinar is over. Please check your emails for instructions on how to access your continuing education credits. Thank you and have a great day.
Thank you.